Comprehensive, relevant, and insightful conversations about health and medicine happen here when MedStar Health DocTalk. Real conversations with physician experts from around the largest healthcare system in the Maryland, D.C. region. Most of us know someone who has been affected by breast cancer. The American Cancer Society estimates that over 4 million women in the U.S. today have survived breast cancer or are living with some stage of the disease. Thanks to improved mammography and advances in treatment, more and more women are being diagnosed at an early stage. Of them, 1 in every 6, according to a Cancer.org report, is diagnosed at stage 0, where malignant cells are contained in a mammary gland. It's known as Ductal Carcinoma in Situ, or DCIS. Today, we will learn more about this early-stage breast cancer and how it's treated with Dr. Maen Farha, Medical Director of the Breast Center at MedStar Good Samaritan Hospital in Baltimore. I'm your host, Debra Schindler. Dr. Farha, welcome to MedStar Health DocTalk.
I think this is interesting. A lot of patients have this disease and they want to hear about it.
So ductal carcinoma in situ. In situ, what a strange name. What does it mean? And how does it differ from invasive breast cancer?
So the structure of the breast is a mound of fibroconnective fatty tissue. And interspersed in the middle of all of that are ducts and lobules. The lobules are supposed to produce the milk, and the ducts carry the milk from the lobules to the nipple. There's probably about 13 or 14 of these systems in the usual breast. The ducts and the lobules are encased with a very thin microscopic basement membrane. Outside that basement membrane are lymphatics, veins, and arteries that supply the blood supply. And cancers that form within that basement membrane do not have access to the circulation and therefore cannot spread. And that's why they call it in situ. The cancer cells are contained within the duct, and therefore they have a near zero chance of spreading to the lymph nodes or somewhere else in the body.
So they don't spread at all. Someone who has a diagnosis with DCIS does not have to worry about it becoming more invasive or spreading outside that nipple?
Left alone, a lot of DCIS will turn into invasive cancer. So that's why the benefit of removing it and treating it before it turns into invasive cancer certainly is valuable for patients. It reduces the chances of them showing up with the disease somewhere else in the body. The only caveat to that hypothesis is that if you take a piece of tissue, for example, 1 inch in size, and you divide it and you take slices and you look under the microscope at these slices, you're only sampling maybe 5% or 10% of that tissue at maximum. Therefore, it is conceivable that some patients who have DCIS may have areas of invasion that may not show on these slices that have been done. So that's the caveat. But overall, if you take all comers, the cure rate for DCIS that's properly treated is near 100%.
Okay. This is a very early stage then of a breast cancer.
Correct. We call it stage 0.
Stage 0.
Some people argue that we shouldn't call it cancer. But that's a hypothetical discussion that's really irrelevant. The bottom line is these are cells that look like cancer cells, and left alone, they will likely or very likely behave like cancer cells.
It is interesting that you say that, because while I was researching this topic, I read that on one site that it isn't really a cancer.
Well, that's why people argue that you shouldn't call it a cancer. It's really a hypothetical discussion. The cells look like cancer cells. Genomically, they behave like cancer cells. They have the profile of cancer cells. But given the fact that they're contained within the duct, if you say cancer spreads, this does not spread. And that's why people argue that we shouldn't really call it a cancer.
Okay. So it's stage 0. It's not invasive. How do women know that they have this? Or men? Men could get this too, DCIS?
It's rare, very rare in men. Most men who present with a breast cancer present with an invasive breast cancer usually, because they present with a mass. And most masses are invasive breast cancer. Most DCIS is discovered on mammography, though. The large majority of patients with DCIS either are found on screening mammography, followed by diagnostic mammography. Few patients present with a mass, and some patients, also a small number of patients, may present with a bloody nipple discharge or clear nipple discharge.
This might sound like a dumb question, but I'm going to ask anyway. Do men have milk ducts?
Yes, they do.
But they don't normally get DCIS?
They're not as developed as the women's.
Which might explain why they don't really get that.
Correct.
Okay.
It's very little amount of tissue.
Okay, so there could be a bloody discharge from the nipple. What other symptoms might there be? And if there aren't any symptoms, how would a woman find out that she has ductal carcinoma?
So the vast majority of DCIS is discovered on screening and diagnostic mammography.
Routine, usually a routine mammogram?
Correct. Screening mammogram is done. It shows calcifications or shows an area of architectural distortion. Then a diagnostic mammogram is done, and then a biopsy that would show DCIS.
What is a calcification? That's not cancer.
Calcifications are frequent in the breast, and calcifications could deposit within the ducts, in vessels, areas of fat necrosis, areas of fibrocystic disease. There are certain types of calcifications that when we see them, recognize them, these are suspicious and need to be biopsied. So the calcifications indicate that something is going on in that area. And that's how we're alerted that there's a problem. The calcifications themselves are not the problem. They're just an indication that something is going on in that area. And this alerts us to the presence of the tumor.
Okay, so the mammogram shows something suspicious.
Correct.
And then the next thing would be to get a biopsy.
Correct. Most of these biopsies are done using stereotactic technique. This is mammography-guided technique. It's done under local anesthesia.
So the patient is awake?
Correct. Using an instrument that we direct into the area of the suspicious lesion, and that instrument will cut small pieces of the tissue that samples the area, and we send it to the pathology. Now, that's done under local anesthesia. It's really, surprisingly, extremely well tolerated, especially if you do the right level of local anesthetic. It's stressful, and the brave women go through it day in and day out successfully, fortunately.
I think I'd rather be under general anesthesia. Can't that be an option?
This cannot be done under general anesthesia because you're sitting in the mammography machine with the breast in compression to do this biopsy. But that's the standard. We do hundreds of these every year here. Over 500,000 are done nationally, or maybe over 1 million are done nationally every year. It's all done under local anesthesia.
I don't even like to have my blood drawn. I
can imagine.
What are the risk factors associated with DCIS? Is there a hereditary propensity for this?
It's the usual risk factors for breast cancer.
Okay.
Inheritance is big, age, smoking, elevated BMI, lack of exercise, all the same risk factors that breast cancer would cause DCIS.
What's the average age of your patients?
I'd say around 55 on the average. But we see patients in their 80s who have DCIS. We see patients in their 30s who have DCIS.
Would you treat a patient in her 80s for this?
So it depends on the amount of disease they have, because it takes time for DCIS to turn into invasive cancer. So if you have a tiny bit of DCIS and you have a patient who has a lot of comorbidities, then you may say we can watch something like that. But if you have a robust 85-year-old who is really active, and many of these are still doing screening mammography despite guidelines, you treat it.
What do you mean in spite of guidelines? Because
the guidelines generally tell you to stop doing screening mammography at a certain age, maybe 75. Some people stretch it to 80. But some women just keep doing it, and you can't stop them. If they ask for a screening mammogram, they get it.
Oh, interesting. I didn't realize there was a cutoff. How do we reduce the risks, and are there any preventive tips? You mentioned exercise. How would exercise prevent DCIS? I'm very curious about that.
Well, whether it's affecting the hormonal environment, increasing obesity, not being consistent with a lot of smoking, and might have positive effect on the immune system. If you think of our body, we have trillions of cells in our body, and these cells keep dividing on an ongoing basis. And errors in the division happen frequently. And many of these cells with errors would die. Many would form into a cancerous growth that our immune system detects and suppresses them. So the immune system, the role of the immune system is really poorly defined. But there's no doubt in my mind that that plays a role in carcinogenesis.
It comes up in every conversation, the need for exercise and sleep.
Again, it might have its effects on the immune system. Inflammation is another factor. Diets that are associated with high inflammation, or diseases that are associated with high inflammation as well.
It sounds like there isn't, the DCIS would not be life-threatening. Is that fair to say?
Itself, it's not life-threatening.
How long can someone go before they are then at risk for it spreading?
It has to turn into an invasive cancer before it becomes life-threatening. And that process might be 1 year, might be 10 years. And again, that depends on the amount of disease, on the person's makeup and their immune system and other factors, their hormonal environment, hormonal exposure. All these are factors that are poorly defined, but they play a role in how frequently these turn into a cancer.
Is it always stage 0? I guess if it elevates to another stage, then it's no longer DCIS. Is
correct.
That right?
If it changes into an invasive cancer, then the staging changes.
Okay, so you talked about the biopsy. Once the biopsy results are back, and how long does that take?
A couple of days, you get the result of the biopsy after it's done. And in addition to looking under the microscope, we test these for estrogen and progesterone receptors. These are receptors within the cell that tells us whether this tumor is dependent on the woman's hormonal environment. Although people might be postmenopausal, but their body still produces estrogenic hormones. And what we find is that suppressing these hormones reduces the recurrence rates for these tumors when they're estrogen and or progesterone receptor positive.
What if a woman is on a hormonal replacement therapy? Would that?
So that's generally thought to be a mild risk factor for development of DCIS and or breast cancer. This subject has been argued upon back and forth for years, but most people settle on the fact that hormonal therapy would increase the risk, but it's not an excessive increase in the risk. It'll be maybe 20%, 25%. So if somebody's risk is 10%, it'll be 12 or 13% net.
It's a discussion about the risk benefit.
Correct. It's always a discussion about risk benefit.
So when you get the biopsy back, do you call the patient, or does she have to come in and you sit down and you tell her what you found?
Depends on the patient. Most patients would prefer to meet them face to face and discuss the result with them. Right. In the patient's mind, even the mere mention of a suspicious mammogram creates the emotional response as if you have a cancer. True. Then you tell them on the phone, you have DCIS, and you try to explain it. That's not going to work. There are a few patients, though, who are sophisticated in their knowledge enough. They've already ingested the fact, they've already done the research, and they say, yeah, you can call me. I understand what DCIS is. At least you can tell them the result on the phone, obviously. And then they have to come in to discuss their treatment. Okay, let's go through that. What are the treatment options? Unfortunately, the treatment options are similar to some degree to invasive cancer. A lumpectomy would be your first Lumpectomy step? Is what most of our patients will undergo. Okay, explain that for anyone who may not know what a lumpectomy is. So if the tumor is localized, we take the tumor with a margin around it. Most of these tumors we don't feel, so the radiologist will have to either put a little wire or a special chip in the area of the tumor so we can find it. So after the patient goes to sleep, we go in and take that tissue, take an X-ray of it to make sure we got what we came after. I usually cut the specimen myself with the pathologist to look grossly if I need to get additional margins, hoping to reduce the chance of having to go back in. And then you close the incision, patients go home. Recovery from something like that is usually very simple, and the risk of the surgery is very small. The biggest unknown is when the pathology comes back. So something about DCIS, since it's microscopic, it's not a mass that you could feel. And many times, or sometimes, it's much more extensive than the imaging tells you. Now, we do get an MRI before the surgery that gives us a hint or a suggestion about the extent of the disease, but even that is not 100% accurate.
Is that when radiation would come in?
So after the surgery, pathology comes back, margins are negative. A large majority of the patients will be offered radiation. Now, there are some patients who we don't offer radiation to, or we don't recommend because there isn't enough benefit from it. And there's a couple of ways to tell that. We talked about the 85-year-old with 3-4 millimeters of DCIS. We talked about patients with very limited amount of disease who are not able to get the radiation. And there's also, we do some genetic profiling of the tumor that gives us a score. It's called Decision RT, which we use to decide whether there's meaningful benefit or not a meaningful benefit from radiation. Meaning they've looked at large number of cases and created a statistical model where doing a bunch of receptors and so on, they give us a score. If the score is less than 3, the research has shown that these patients have very little benefit from the radiation. If the score is above 3, there's increasing benefit of the radiation. So it's not a straightforward decision. And then there are the patients also who have localized disease, who are not willing or who have really limited disease, where we might do intraoperative radiation, do the radiation for them while they're under general anesthesia.
Also known as IORT.
IORT, yes.
Share with us what that is.
So the usual course of radiation extends from 3 to 6 weeks. And the usual course of radiation radiates the whole breast. And studies have shown that in many patients, radiating the normal tissue does not reduce the incidence of new cancers. So when we know the disease is very well localized, whether it's invasive or DCIS, when we have a good feel that this is a localized disease, we just radiate the rim around the tumor bed intraoperatively over the span of 8 or 10 minutes. It delivers one dose of radiation, which is biologically equivalent to the 3 to 6 weeks of radiation to that area. There's some nice things about it. One is convenience. 2 patients.
Yeah, it sounds like a great option.
Yeah. Patients who are unwilling to go, you're worried they're not going to cooperate with the radiation, or they just can't raise their arm enough to have the standard radiation. Or the older patient where you want to radiate them, but it's very hard for them to do that. Covers some geographical areas. I've treated patients who live far from here, and they wouldn't come every day for 4 weeks or 5 weeks. So we do the intraoperative radiation if appropriate. So there are, and it saves money as well. It's cheaper than the standard radiation.
What about chemo? Is chemo a part of the plan?
Not for DCIS.
Well, that's a comfort, I'm sure, for your patients.
So the indication for chemotherapy is when there is concern about the disease showing somewhere else in the body. Because surgery and radiation will take care of the local regional disease in the breast. But if there are cells hiding in the liver or the lung that will show up later, that's where chemotherapy comes in play. And since DCIS has a near zero chance of doing that, then there's no benefit from chemotherapy.
But I have read that mastectomy is an option for DCIS. And if there's little concern about it spreading, why would someone opt for a mastectomy? So
there's a number of factors there. One of them, the woman can decide on having a mastectomy if that's what she wants. Some women say, I don't want to deal with this. And it's surprising the profile of people who say that. You think that a younger patient might never want to say that, but the younger patient might say, I have 2 daughters who are 7 and 8, and I don't want to worry about this for the next 20 years.
Right.
And they might say, I'm going to have a bilateral mastectomy. Some do that. And so that's first, the patient has that choice, of course. But then suppose you have a lot of disease in the breast. We have a patient a couple of weeks ago, there's about 15 centimeters, 6 inches of DCIS. You have to have a huge breast to be able to take that with negative margins. Then the ratio of the disease to the size of the breast also. And how can you come out with a cosmetically acceptable outcome? Acceptable to the patient, of course.
Right.
So all these are factors in deciding. For some patient would say, this is pretty localized. You could do just a lumpectomy, or you can do a mastectomy if you want. But some patients would say, you're not the optimal candidate for this. And despite that, they might say, I want to try it. We try it. If it doesn't work, we go back and do the mastectomy.
What did you decide with the patient who had the 6 inches of DCIS?
Well, she decided that she wants to give it a shot. We gave it a shot. We told her that there's a very high chance of this not working.
A lumpectomy?
A lumpectomy is not going to work.
Okay.
And sure enough, the margins showed a lot of disease and unexpected disease. So we'll have to go back and do a mastectomy for her.
With a reconstruction. Can you reconstruct if you have to take that much breast away?
Yeah, you can reconstruct the breast. As long as you leave a nice skin envelope, you can reconstruct the breast, or you can use implants to stretch the skin to create enough of an envelope.
And because it's in the milk duct or the mammary gland, are you able to keep the nipple? Or does that have to go
Depends on the location of the lesion.
I see.
Lesions that are close to the nipple areola complex would require to have the nipple areola complex removed. Lesions that are further away, you can save the nipple. You don't have to remove it.
Once a patient goes through a treatment for DCIS, what is the likelihood that they're going to have the same disease come back?
So the recurrence rates for DCIS that are properly treated vary. For the usual limited disease, the recurrence rates for a lumpectomy and radiation followed by endocrine therapy is about maybe 5%. For a mastectomy is about 2%. The patients may choose based on that factor. But when we looked at long-term survival data, there is no difference in survival between the lumpectomy with radiation versus mastectomy. And there are many hypotheses why that is so, despite the higher recurrence rate. Now, remember that after lumpectomy with radiation for DCIS, although the recurrence rates are small, when they recur, 50% of the time it's DCIS, 50% of the time it's invasive cancer.
But it's a new cancer, right? It wouldn't have been...
So it could be a cancer in the bed of the tumor within a short period of time, 2, 3, 4, 5 years. That's a true recurrence. Or it could be a new cancer. What we see more, I'd say there's 50-50. Some of them are new cancers. Some of them are true, what we call true recurrences. Now, to reduce the chances of new cancer and recurrence, patients who are estrogen or progesterone receptor positive are offered endocrine therapy. So these are pills that by blocking the synthesis of estrogen or blocking the estrogen receptor will reduce the recurrence rates by 50%. And most patients will take them. They have some side effects. About 30% of the patients cannot tolerate them very well because of body aches or hot flashes, or they just don't want to take anything.
What are the most common concerns that your patients share with you when you inform them that they have DCIS?
The first concern for everybody is a life and death concern.
Sure.
The second concern is, am I going to need chemotherapy? The third concern is, am I going to lose my breast, and how is it going to look after surgery and radiation? These are the commonest concerns that patients express.
I can imagine.
And they vary depending on the age and the personality and the background of the person. There's no doubt. It's very personalized.
I'm sure after you talk with them, they go from panic to relief.
So they're always relieved, and we want to make sure that this is not life-threatening. We know how to deal with it, and you're going to be fine. That's always a very relieving thing. And then when you get into the details of all the things that you have to do, that's kind of bothersome. I wish there was a study looking at just doing endocrine therapy for some DCIS patient. The results of that study are not out yet, meaning no surgery, no radiation, just take the pill. That study has not matured yet. I think they completed enrollment of the patients, and we'll see what the results. It takes 10, 15 years to study these outcomes. So they don't come out very quickly.
What do you think we can hope for in terms of what's on the horizon for this kind of cancer, or non-cancer as it is, this kind of breast disease? And what about clinical trials? Are there any clinical trials that patients should know about if they have a diagnosis of DCIS?
There are some clinical trials. One of them would be radiation, no radiation for limited amount of disease. One of them is that trial that closed now, trying standard treatment versus just endocrine therapy. That should mature. We should start getting results over the next 4 or 5 years. What ideally, could we come up with something a biologic that might just stop DCIS in its tracks? We don't have that yet, but there's the promise of that. We've seen enough progress in so many things with breast cancer that I wouldn't be surprised if something like that comes up over the next 10 years.
A woman who gets this kind of diagnosis, what is your projection as far as how long this journey will last for her, from the time that she's diagnosed until the time that she is free of DCIS?
Meaning until she completed treatment. Is that...
I talked to a young woman many years ago who, she had invasive breast cancer and had the mastectomy, and she took that in such stride. She told me, I told myself, I'm giving myself 6 months. I'm going to take 6 months out of my life to take care of this, and then I'm going to get on with my life and put this behind me. She predicted a 6 month, and I'm sure she predicted this 6 month journey based on her conversations with her care team. But DCIS seems like it may not be as long as that.
So if the patient chooses a lumpectomy, after 2-3 weeks, they're fine if their margins are negative. And if they do the standard radiation that's designed around their schedules, usually, the radiation episodes are short. You come, get treated, takes about 15 minutes, and you leave. You go back to work, you go back to life. The radiation oncologist will see these patients once a week during the treatment. So that is not disruptive. A mastectomy requires more to recover from. Sure. You add reconstruction, that adds another month to the mastectomy.
You wouldn't do the reconstruction at the time of the mastectomy?
You could do it. But if you do it at the same time, the recovery becomes longer also. If the recovery from a mastectomy alone is 4 to 6 weeks, add 4 to 6 weeks to that to really recover over the reconstruction.
Do you have a story of hope for us that you could share?
Yeah, patients do very well. The vast majority of patients don't see the disease, and we can, to a good degree, predict the extent of the disease, how dangerous it is, and what needs to be done for it to be treated and cured. And patients do very well.
There seems to be some controversies involving the guidelines for DCIS management. Can you share any insight to that?
Are we doing too much is the question. We always want to be as economic as possible. We want to inflict as little suffering, pain, treatment on patient as is necessary for that particular patient. And the question is, which patients don't need radiation? Maybe patients don't need 5 years of endocrine therapy. Maybe some patients don't need it altogether. So these are questions that have not been answered, and research needs to be done to answer these questions. Because not only is there an economic cost, but also personal cost for the patients. Body aches, arthritic symptoms are not easy for active people who want to run, who lead active lives. So reducing that cost to the patient is very important.
Who would make those decisions? Her care team, I guess. A patient can't know what she doesn't know. So she needs input from other specialists. So
as you can see, in the care of this patient, you'll have a radiologist, often involved in the diagnosis, a pathologist reading the slides and doing the testing, a surgeon operating on the patient, a radiation oncologist who gives an opinion about radiation and gives the radiation. A medical oncologist usually takes care of the endocrine therapy for the patients. And we work together as a team. So once we work up the patients, we see them together, we discuss them in conference, and we see them together as a team. And they usually bring their families with them, their support, their spouses, their neighbor, whatever. And we'll have a real live discussion about their treatment. And there's some authenticity about it and immediacy instead of going to 4 or 5 appointments, different times, different days, where there could be confusion and uncertainty.
And that's what we call comprehensive care.
Comprehensive multidisciplinary care.
Very important. Is the patient also offered advocacy or community support?
There are support groups. I see smaller uptake. People are taking more onto social media for support.
Oh, interesting.
And most patients will have their own circle of support, which is important for them.
Okay, so what are the key takeaways? Let's summarize.
The key takeaways is make sure the disease is limited and there isn't anything else missed. And if it is all DCIS, the vast majority of patients will do extremely well. And the vast majority of patients will have choices of keeping their breast. What you have to do is learn about your disease to make the best decision that's optimal for you personally.
Perfect. Thank you, Dr. Farha.
You are welcome, Debra.
We've been talking with Dr. Maen Farha at MedStar Good Samaritan Hospital in Baltimore. Thank you for sharing your expertise with us here on DocTalk. To learn more about DCIS, visit medstarcancer.org or call the Breast Center at MedStar Good Samaritan Hospital at 443-444-4673.